Good morning, everyone. It's me again, Professor Omuna, with the last session on specific immunity and B lymphocytes. The actors of the immune reaction. The organs of the immunity: bone marrow, the thymus, spleen, lymph nodes, and the lymphoid tissues are the place of the production and differentiation of cells of the immunity. The antigens, triggering factors, are most often proteins. Lymphocytes are the effector cells of the immune response. They include B lymphocytes and T lymphocytes, among which two subpopulations are specially distinguished: helper T cells, called CD4 cells, or T helper cells, and suppressor or cytotoxic T cells, called also CD8 cells. Antigen-presenting cells, or APCs, capture the antigen, condition them, and present them in the immunogenic form to lymphocytes. MHC molecules, major histocompatible complex, also play a major role. The antigen, or the triggering factors. At the origin of any immune response, there is the penetration of foreign element, which on the one hand triggers the immune reaction. This is the immunogenic effect. And on the other hand, react with specifically with the product of this reaction. This is the antigen effect. Antigens are many and varied: bacteria, viruses, parasites, foreign cells, toxic substances, and drugs. Only certain structures called antigenic site or determinant or epitope are active. The bone marrow. Everything starts the bone marrow, at least for the immune cells. The bone marrow, the equivalent in birds, is the Fabrius's bursa. In the place is the place of the production of all immune cells and hematopoietic cells. The lymphocytes which inhabit are called B lymphocyte, in English, bone marrow, for, of course, B for bursa. And you see here, the first time the B cells have been discovered in bone marrow, in the bursa of Fabrius, but in the bird, the production is always in the bone marrow, but the differentiation is in the bursa of Fabrius. For mammalian, everything for the B cells start in the bone marrow and remains in the bone marrow. And what do we have? Potent hematopoietic cells differentiate into determinant progenitors, which are the source of all blood cells: red blood cells, platelets, monocytes, macrophages, pro-T lymphocytes, and pro-B lymphocytes. We have seen earlier that pro-T lymphocytes will leave the bone marrow to go to complete the differentiation in the thymus, while B lymphocyte or pro-B lymphocyte, they remain in the bone marrow at some degree. Beside its function as a producing organ, the marrow also acts as a primary lymphoid organ for the differentiation and maturation of B lymphocytes. And here we see very important that the bone marrow has the inhabited as stem cells, what we call stem cells, and we will have three lineage: lymphoid stem cell lineage, myeloid lineage, and erythropoietic, which means red blood cells. Most of the cells will leave the bone marrow, such as the lymphocyte, T lymphocyte, and they will reside in the thymus. In the thymus, they will differentiate into either CD8 cells or CD4 cells. We will have also NK cells. They will leave the bone marrow and go to specific organs, and that belongs to what we call myeloid cells, or innate immunity cells: mast cells, basophil, neutrophil, monocyte, macrophages, eosinophils, and NK cells. The B lymphocyte will remain in the bone marrow until some stage, and then they will go to the spleen and secondary lymphoid organs. Medullary selection. We have seen for T cells, lymphocyte to T selection. Here we will see the B selection, and of course they will undergo selection very drastic in order to avoid specifically autoimmune disease. Since BCR, which is B cell receptor, are produced at random from genetic rearrangement, there is also a risk that these cells will recognize self-antigen as foreigns. So it's a nightmare. It's a very big issue that our immune cells, specifically T and B, will recognize our self-antigen as foreign antigen. B lymphocyte carrying such receptors must therefore be eliminated. They will be killed. Bone marrow cells express MHC class 1 and 2 molecules, which they present to immature B lymphocytes. If the B lymphocyte or BCR recognize MHC molecule, which means they will bind, that will lead to the death of the lymphocyte by apoptosis. If the BCR does not recognize, which means does not interact with the self-antigen with the MHC, it will be selected, becomes immune competent, and leave the bone marrow through the blood. B cell development, as you see here, we have seen, of course, the pluripotent stem cells. We will have the myeloid stem cells that will give us the innate immune cells, and we will have the lymphoid stem cells. Lymphoid stem cells give us the T cells that will maturate in the thymus that we have seen, and today we will concentrate on B cells. As you see here in pink, it's mainly B cells development in bone marrow, pro-B cells, pre-B cells, and we will see already that the cells have already the IgM heavy chain and inside the cells. Once they will leave the bone marrow and go to the spleen, the lymphoid organs, secondary, such as lymph nodes, and of course, Peyer's patches and the sinus, we will see here that they will undergo maturation. We will have immature B cells expressing already IgM and IgD, and will interact with T cells. This interaction is extremely important to produce certain classes of antibodies. Some of the cells will remain expression and secreting IgM, as you see here, and some of them will undergo switching and will be secreting IgG or IgA or IgE. In order to produce these three classes, IgG, IgA, and IgE, they need the interaction with T cells. That's what we call T-B cell interaction. But if they would like to produce, if the antigen, of course, will allow it to produce IgM, they do not need this interaction. So we will see today all this differentiation, but I would like just to emphasize on this, what you see here in red. This is what we call genetic defect. Babies sometimes are born with some genetic defect, especially for the immune cells, and the higher the defect is in the development of our cells, the mortal or the lethal it can be, such as ADA, adenosine desaminase deficiency. The baby is born with this deficiency, with this enzyme. They cannot have neither T nor B cells, and you can imagine that these babies cannot survive unless they will have a bone marrow transplant. Some of them, they will have, of course, deficiency in MHC. Some of them, will have some receptors. And for the B cells, already some babies that are born, and when you see X-linked, which means that it's boys, they have agammaglobulinemia, which means they have no antibody whatsoever. So no B cells maturation, and they will have T cells, but they cannot have B cells. Some of them maybe can die or can suffer from antibody deficiency. And some of the baby, they have the hyper IgM syndrome that we will see later, which means they have only IgM, but no IgG, nor IgA, nor IgE. So naive B cells, just when they leave the bone marrow and go to reside in the spleen or lymph node, they are already IgM, IgD positive. IgM, IgD, and we will see the function of, especially for IgD. When they capture the microbe, they will behave like antigen-presenting cells. They will be activated, they will present it to T cells, and they will undergo clonal expansion. They will undergo differentiation. The first antibodies that are produced are mainly IgM, since they are already on the surface of the cell. That's why, for example, for coronavirus, we see always, when we would like to know serology, for example, after a vaccine or after infection, we will have always a peak of IgM and then IgG. Why the first one is IgM? Since IgM is already on the cells. And then after class switching, you will have IgGs. And of course, you will have maturation, and you will have memory B cells. So basically, normally, after COVID infection or any infection, we should have memory B cells, or after vaccination as well. The interaction with T cells is extremely important. Here is you have lymph node. Here you have just part of it. You have, of course, antigen presenting cells that will present the antigen to naive CD4 cells. And we have seen that T cells they cannot capture. They will always wait that any antigen presenting cells will do the job and present it to them. And then they will undergo differentiation. In the meantime, the same antigen can be captured by the B cells. Since they have the capacity to capture, they will undergo some presentation and, of course, clonal, and then they will go to the T cells and communicate T-B cell interaction. And here we will have class switching. For the first time, we can produce IgM without the need of any contact of T cells, and then they will produce IgGs or IgA or IgE. This will be determined by the nature of the antigen. Immune reaction. The penetration into a new organism of a substance or molecule or cell called antigen creates a new situation in this organism. This organism is called immune. The situation is established because a reaction develops, which is called the immune response, and which consists of a proliferation of lymphocytes sensitized to the antigen. This is the primary response during which lymphocytes will multiply for life, long cells called memory lymphocytes. So if someone is infected with any antigen, is already immune, since he has developed antibody or T cells or memory cells. The same situation with vaccine. During second penetration or contact of the antigen, the immune reaction is faster in its effect and more efficient because it is accelerated and amplified by the memory lymphocyte, which multiplied during the primary response. This reaction is called secondary reaction. And here you know that your memory cells are really here to protect you in case you will have another interaction with the antigen. So if you will take an antigen here, the first reaction, our naive cells, IgM, IgD, positive, will capture, will undergo, will be activated, will undergo clonal expansion, and then we will secrete. The first antibodies secreted are usually IgM, but this reaction is quite long, 10 days and more. That's why if you would like to know if you have been vaccinated or infected by COVID, you have to wait at least 10 days to know that you have small peak of antibodies. And then the cells will undergo apoptosis, most of them. And of course, some of them will remain in the system, especially in the bone marrow or secondary lymphoid organs as memory cells. When you have a repeat infection with the same antigen, you will have secondary response. And here, secondary response is faster, 5 days, much better, and especially on terms of class of the antibody is higher. You have IgGs, IgM, IgGs. IgGs are more, the affinity is higher, much more important. Of course, IgGs are secreted. They will neutralize the virus or the bacteria or the parasite, depend on the antigen, and of course will undergo also apoptosis and what remains in our system, memory. It's extremely important to know that in order to have these cells working like in this textbook slide, you need to have healthy cells. They have no much oxidative stress. The person is not too much stress. On all the situations, especially keeping, as long as we can, memory cells, we need to take care of our system. And that's why some antioxidant, some products that can help us, of course, reducing the oxidative stress, reducing the disorientation of our cells are needed, especially nowadays. The preliminaries. The antigen is synthesized by antigen cells, phagocyte, which take up the antigen, modify it, and present it to lymphocytes associated with MHC class II. T lymphocytes that have the receptor for the antigen, TCR, then come into contact with it through the TCR receptor associated with the CD3. We have seen that. Are activated, these cells, by this contact and undergo lymphoblastic transformation. B cells can recognize the antigen in its native form. Again, T cells, they need other cells to present them the antigen. B cells, they have the ability to recognize the antigen in the native form. T helper lymphocyte, B lymphocyte cooperation, TB cell interaction. Under the reaction of the helper lymphocyte, the B lymphocyte multiply, transform into producing IgM antibody, and then switch. This is the switch into the carrying membrane IgG, IgA, or IgE before differentiating in plasma cells secreting these same classes of antibody, which means the cell in the beginning is IgM, IgD. After the contact with the antigen, it will produce IgM. We need that. It is not very, the affinity is not high, but we need that at least to block or neutralize the virus. And then we will have the switch, IgG, or it mucosal IgA, or it parasite IgE. First, the antibodies are on the cell, and then they will be secreted. Some of the cells will have long-lived memory B cells, what we call memory lymphocytes. Antigen stimulation causes lymphoblastic transformation of those which possess the receptor site of the antigen, which generate the immune reaction, membrane immunoglobulin of IgM class, and then multiplication in effector B cells, which differentiate into plasma cells, which secrete the antibodies or antigen-specific immunoglobulin. Does that mean that the cell that did undergo the first reaction will never produce IgM? No. In some bacteremia, infection of bacteria in the blood, we need IgM. So basically, the cell can remain always producing IgM or switch. As I said, the antigen will determine which class of antibody we will need in order to have better protection. Evolution of the antibody level. The first antibodies never appear after a period of a few days, which will, in the most sensitive detection method, is never less than 24 or 48 hours. Really appreciable levels of circulation or circulating antibodies appear between the 6th and the 7th day. It is mainly IgM. The level of these antibodies then increases gradually to reach a maximum around the 3rd week, not semester, sorry, the 3rd week. This is a mistake. Then draw a plateau which bends more or less quickly thereafter. So here we have it's extremely important. The primary response take usually 5 to 10 days. The secondary is faster. The peak is smaller, secondary is larger. The antibody isotype, usually IgM, few IgGs, and then a relative increase in IgG, and under center situation, IgA, IgE. Antibody affinity, low average affinity, high affinity. That's why we need always secondary exposure in order to have better class of antibodies. So the cell capture, B cell captures the antibody, the antigen, sorry, undergo mitosis, which is colonal expansion, will express costimulatory molecule, and then start by producing IgE. This is IgM. This is extremely important to know that the first mainly antibodies are usually IgM. We have seen this slide. The differentiation of B lymphocytes takes place from the embryo and continues throughout our lives. Before birth, the yolk sac for the birds and fetal liver, as well as the bone marrow for the human or mammalian, are the main site of B lymphocyte differentiation. After birth, the bone marrow is the main site. After encountering the antigen and activation, part of the B lymphocyte differentiate into cell-secreting antibody, the plasma cells. The rest give rise to memory B lymphocyte. These stages of differentiation can be divided into 2 phases. The first one is antigen independent. It mainly plays in the bone marrow and a little bit in the secondary lymphoid organs. So what we have, stem cells, pro-B cells, pre-B cells, cell or B cells immature, and then mature naive B cells. This phase is always independent of the antigen. The second one is antigen dependent. Mature B cells circulate in the blood and the lymph and are brought to secondary lymphoid organs, especially the spleen and lymph node. The antigen dependent take place in these organs. If the B cell interact with an antigen for which the membrane antibody is specific, the cell undertakes clonal expansion and differentiation, which result in the population of plasma cells and memory B cells. In the absence of recognition of a foreign antigen, the mature B lymphocyte will die. So B cells leaving the bone marrow go into the secondary lymphoid organs, spleen and lymph node. If they don't have any contact, they will die and other cells will replace them. Now, if B cell has recognized a foreign antigen, it will receive a survival signal and progress to the apical clear zone. Activate B lymphocyte, undergo the phenomenon of class switching, which allow them the expression of isotype other than IgM or IgD. This class switching takes place as a result of cellular cooperation between B lymphocytes and CD4 T cells, which result from recognition of B lymphocyte CD4 T and the CD4 T ligand and take place in the presence of anti-leukemia. So differentiation leads to plasma secreting IgG or IgA or IgE and memory lymphocytes. Memory B cell have a longer lifespan than naive B lymphocyte, and the affinity of their membrane antibody is greater as a result of selection of somatic mutation. Memory lymphocyte most often express IgG if they have secreted IgG, or IgA or IgE. Plasma cells membrane anti-immunoglobulin, but secrete a large amount of antibody. So naive B cells, they will undergo immunoblasts, immunocytes, and plasmocytes, which means they will produce antibodies. So start with stem cells. We will have pro-B cells, and then pre-B cells, and we will have already expression IgM and IgD on the surface. So far, this happened in the bone marrow and then undergo into the circulation. If the B cell first has been interacted with IgM, especially, for example, bacteremia, infection in the blood of bacteria, with bacteria, for example, they will secrete IgM. They will always secrete IgM because we need that. And then we will have memory IgM B lymphocytes. Now, if the first interaction has started with IgM, there will be a switch to produce IgG, and then we will have plasmocyte producing IgG and memory cells, IgG, memory B lymphocytes. Now, we start with IgM, mucosal immunity, especially digestive. We need IgA. Then we will have plasmocyte, IgA secreting cells, and memory B lymphocyte, IgA B lymphocyte. IgM, we have a parasite, we will switch to IgE, IgE producing cells, IgE plasmocytes, and memory lymphocytes. Always like that. Antibodies. There are immunoglobulins made up of glycoprotein comprising 4 chains, 2 identical heavy chain and 2 identical light chain joined together by disulfide bridges. Immunoglobulin have a Y structure. The 2 branches of the Y constitute the FAB, fragment antigen binding, by which they can capture the antigen, the ends of which are the antigen binding site. The foot is called also FC fragment, crystallized fragment or crystallizable fragment. It carries the class specificity of the antibody supporting specific effector function. Here you have our BCR, which can be IgD, and through this it can capture the antigen and then also start the phagocytosis as well as the clonal expansion. Here we have an antibody with light chain and heavy chain and the bridges, of course, with disulfide. Antibodies synthesized by plasma cells diffuse in the serum and humors and bind to antigen to form immune complexes, which are eliminated by phagocytes. Antibody belonging to certain classes are able to activate the complement system, specifically IgM and IgG, once they are attached to the antigen. And remember, bacteremia, we said in the blood, and in the blood we have IgM mainly, or IgG, and that these two antibodies can stimulate the complement. Here we have the two slides, IgG and IgM. You see that mainly the FC receptor or FAB is almost looks the same, while the FC fragment crystallizable is different. And we can see here how the two light chain, the two heavy chain, FAB, fragment antigen binding, it's like arms and hands that can capture and neutralize the microbe. Characteristics now of the five classes: IgA, IgD, IgE, IgG, and IgM. For IgA, we have two subclasses or two subtypes, IgA1 and 2. For the IgG, we have 4, IgG1 until IgG4. Serum concentration, half time on days, they can remain IgA 6 days, IgD 3 days, IgE 2 days, IgG 23 days. That's why if you are infected with IgGs and mainly you wait more than 3 weeks, you cannot see them mainly. They can also disappear a little bit. So just keep in mind, if you are asking as a doctor or a patient for IgM and IgG, that IgM can disappear just after 5 to 10 days. And then IgGs, they cannot stay longer than 1 month. So basically, if a person would like to have a reaction for a vaccine, for example, they have to do the serology within 3 weeks. Secreted form. Mainly, all the antibodies they have a monomeric form, monomer, IgE, IgG. But some of them, IgA, they can be dimer, 2 monomer, or trimer, 3 monomer. And the most beautiful of them is the pentamer, which is 5 monomers. Function. IgA, mucosal immunity, we have seen that. Neonatal passive immunity, usually given with the milk to the babies or mammalians. IgD, you see, the secreted form doesn't exist. Why? Because IgE is the immunoglobulin receptor by which B cells can capture the antigen and then undergo, can phagocyte, engulf, and of course present it. So IgD is not secreted, it is always on the surface of the cells, helping B cells to capture the antigen. Naive B cell antigen receptors. IgE, mast cell activation, activate mast cells, basophile, and of course we can find IgE in hypersensitivity, allergic reaction. IgG, opsonization, trigger the complement activation, antibody development cell mediated, they can help also NK cells to kill, and of course we can find them also in neonatal. Why IgGs? Because IgGs is the only antibody that can cross the placenta during pregnancy, for human, because for some animals it doesn't cross. And IgM, naive B cell receptor, since we have seen that naive B cell, immature, they are already IgD, IgM positive. And both of them, they can play a role of receptors and, of course, activate the complement. IgG subclasses. We have 4. Do we need to know? Yes, it is extremely important to know the classes and the percentage of each class, since some, especially babies and children, they have some infections. And when we measure the total IgG, we will find it correctly, 70% or 60%, but we don't know exactly what subclass is missing. IgG immunoglobulins are divided into 4 subclasses, IgG1, 2, 3, and 4. The respective plasma level of which show significant inter-individual variation, as also vary with age. IgG1 constitutes 65%, IgG2, 25%, IgG3, 7%, and IgG4, 3%, which means if you are measuring sometimes the total IgG and the child doesn't have IgG2, which we will see the role just after that, you will have 65 and 7 and 3, which means you have 70%. You will say the child is okay, but he is missing 25% of the whole IgG2, and IgG2 are playing a major role, especially in some meningitis and pneumonia. Under physiological conditions, the half-life of IgG1 and 2 and 4 is 21 days. You also to keep in mind, you would like to know subclasses, you have to do it within 3 weeks, while IgG3 does not exceed 9 days. If you have pneumonia, for example, I would like to know IgG3, you have to measure it very early. Benefit of determination of IgG subclasses. Faced with any clinical situation of recurrent infection of upper respiratory, sinusitis, and nasopharyngitis, or lower bronchitis or pneumonia, for which several courses of antibodies prove ineffective, a dosage of IgG2 and 3 is strongly recommended. If you see a child come in with either bronchitis or pneumonia, and you measure IgGs, and you realize that your IgGs are correct, but you didn't measure the subclasses, you are missing something in the lecture. Why? Because even in presence of total IgG concentration you need, because IgGs play major role, especially IgG2. We will see just in the coming slide. So here is our pentamer, IgM, and here are the properties of our IgGs. Major characteristic, most abundant, especially for all antibodies. IgG1 protects the surfaces, especially mucosal. IgM very efficient against bacteria infection in the blood. IgD mainly lymphocyte receptor, and IgE initiate inflammation raised in parasitic infection as well as in allergies. Do they bind correctly to their antigen? Yes. Complement fixation, they activate the complement IgG and mainly IgM. Cross the placenta, only IgGs, and especially we know that IgG2, for example, does not really cross the placenta. So the babies, they will rely mainly on the breast milk. And then, of course, you have to know, otherwise you can miss something in the diagnosis. Activate mastocyte and basophile, of course, IgE, and of course, activate macrophages and neutrophils, IgG mainly, and some Ig. B-cell stimulation. The humoral response is initiated when B lymphocyte encounter antigen in lymphoid follicles of lymph node and spleen and diffuse in the lymphatic organs. This organ constitutes the place of concentration of antigen. We have said that the lymph node as the spleen, they can concentrate as well as the pair patches, the contact between the antigen and lymphocytes. Here, in our case, B lymphocyte, but they can do also with T lymphocyte. By binding to the immunoglobulin Ig receptor, the antigen triggers biochemical signals. Polysaccharides, lipid, and other non-protein molecules contain several epitopes in each molecule, and those manage to bind simultaneously to several Ig receptor in the B cell, especially if you have polysaccharides like bacteria, lipid, and other non-protein. Here we have our IgD or IgM receptor, and you have the microbe, and then you will have, of course, the signal sent to the nucleus with NF-kappa B and starting to producing our antibody. So IgD and IgM are the receptor, and of course the signal will be sent. Now, do we have kind of security measures in order not to produce antibody against any foreign antigen? Yes. The first one is the complement. If you have a microbe infection in the blood, bacteria or virus or parasite, usually it will activate the complement. And then we have seen the cascade, and one of the part of the complement, C3d, will bind, will label the antigen. The antigen will go into the spleen or the lymph node, and then will be in contact with the B cell. The B cell, through the IgD or the IgM, will capture the antigen. But you see here, we have two signals. One is the CD3, which is the complement, and the receptor CR2, and 2, the antigen through the IgD or IgM. If you have these two signals, you have B cell activation. Why? We are sure through the complement that we have an infectious agent and not any antigen. Otherwise, we will have antibody against any foreign antigen, and then we will have allergies and some autoimmune diseases. IgM and the complement, of course, we have seen that IgM activate the complement also. So IgM has already fixed or captured, neutralized the antigen, microbe IgM, and then go bring, but also activation of the complement and bring the whole microbe with C3D, which is mean the complement, to the phagocyte, to the monocyte, in order to finish the phagocytosis, what we call also opsonization. The opsonization is a normal phenomenon, especially in the blood. You have the antigen, you have the antibody, activation of the complement, C3D will almost encounter the antigen, and then you will have the receptor. One receptor is for the antibody and the other receptor for the complement, and then you will have phagocytosis. Antibody and the complement. B cell express receptor for proteins in the complement system, which will signal for the cell activation. Complement proteins are active by microbes and by antibody attached to microbes. Following their activation by a microbe, the later is enveloped by the C3b, complement 3b, enveloped. That's what we call opsonization. B cell then recognize the antigen, will also attach to the 3b. This phenomena is called the concept of two signals. One signal is done by the complement, C3b, and the other signal is done by the antigen itself. And then the B cell knows exactly that it is dealing with an infectious agent, and then undergo clonal expression and produce antibody. Antigen presentation by lymphocyte. We said that B lymphocyte can also play a role. B lymphocyte, which bind an antigen through their specific receptor, will phagocyte the microbe and put it in endosomal vesicle and present it to CD4 cells. And you see here that the B lymphocyte has captured the antigen, undergo, of course, the phagocytosis, expression co-stimulatory molecule through MSC class 2 presenting the antigen. That's why B cells are also called antigen presenting cells. To whom? To the CD4 cells. So the CD4 cell will have two signals. One, the antigen presented by the B cells, and two, the co-stimulatory molecule. So it's very nice. The B cell, in order to start the activation, needs two signals. One by the antigen and the second by the complement, C3b. Now, the T cell needs two signals. One by the antigen presented by the B cell, and two, the co-stimulatory molecules, B7. And you see that we are always having some security, some ways to avoid any multiplication, any division of the cells if it is not needed. T-B cell interaction, we have seen that already. And you see here how difficult to start any activation. The first, the B cell has recognized the antigen, captured the antigen, and of course the complement has helped this recognition, and then now the antigen has been captured and presented, CMHC class 2. The B cell has presented also B7 molecule, co-stimulatory. Now the T cell has two signals, the antigen and through the CD28. Look, the B cell also is expressing CD40 receptor. And there is an expression of the CD40 ligand, which is the opposite receptor. You see, you need 1, 2, 3 signals. And this third signal, the CD, what we call T-B cell interaction, is needed to switch the class. Without this CD40 ligand, the B cell can produce only IgM. when we have the CD40 ligand, through the cytokine, the nature of the cytokine, the B cell will switch from an AGM producing cell to an IgG or IgA or IgE producing cell. So extremely important, all those measures in order to present and to produce the right antibody. Class switching. Helper cells stimulate naive B lymphocytes to produce antibodies specific for each antigen. Those class switching allows to the humoral immune response to adapt to different microbes. The extracellular phase of the bacteria and viruses needs the opsonization, and here we have IgG1 and IgG3. So which means if you don't have some subclasses, you cannot react against the extracellular phase of bacteria and viruses. Helminths are eliminated by eosinophils. The parasite will be enveloped by IgE. If you don't have IgE, you can be harmed or killed by parasites. Hyper IgM syndrome. Why do we have, in some cases, we have talked about that. This syndrome is characterized by the presence of high level of IgM contrasting with the total absence of immunoglobulins from other classes. It is usually genetically, several anomalies have been implicated. We have seen that. So this is B cell, this is T cell. B cell is expressing antigen through CMS class 2, expression the B receptor costimulatory, CD28, TCR receptor, and then you will have CD40 ligand. For some babies, they will be born without this CD40 ligand. The defect is on the T cell. The B cell is normal. Its expression, the 3 receptors, MHC class 2, B7, CD40. But unfortunately, these babies, they have the TCR, they have the CD28, but they don't have the CD40 ligand, which means the B cell is trying to ask the T cell, can you help me to switch? The helper cells cannot. And we have this is an X-linked, which means only boys they have, since with the girls, the X of the mother and the X of the father, one of them, the defect one, can be masked by the other one, while the Y unfortunately cannot do the job. T helper cells from patients with this syndrome do not express CD40 ligand in their membrane, since an interaction between CD40 and on the B cell surface and the CD40 ligand on the T cells is needed. So if sometimes you don't have any antibody, do not always look on the B cells. Try to have a look on the T cells, since the T cells can play a role in the nature and the class of antibody. This syndrome is due to an anomaly on the class switch process. B can only secrete membrane IgM in general by default of cooperation. The absence of the costimulatory signal inhibits class switching, the formation of memory cells, and the production of the germinal center. IgG and IgE cooperation, or you can see the role. IgG, of course, they can bind to any bacteria or viruses, and they can trigger. Of course, that's what you call antibody-coated cell, and then trigger the NK cells to kill this cell. IgE, they can bind to parasite, activate eosinophils, and that's why it's extremely important to kill, for example, helminths. Large parasites, you have, of course, 3 antibodies, and you can activate macrophages, NK cells, and eosinophils. There is always a cooperation between cells and innate immune cells and specific immune cells. IgE and mastocyte. Here we have captured the microbe, for example, some cases for IgE, and then activate mastocyte in order to recruit, for example, neutrophils. And unfortunately, we have also IgE implicated in allergies. Antibody, antigen, IgE, and of course, we will have the degranulation, and of course, the release of histamine and leukotriene and prostaglandin, unfortunately, in these cases. Mucosal immunity. It is specific. Why? Because it's only time when you have the antibody produced by plasma cells as monomer, they will of course bind as a dimer, and then they will leave the organ, which is the intestine, for example, and go and play a role into surveillance. They will of course try to capture the microbes before they will enter. And since we eat a lot of things, and sometimes that can be infected, so we have this IgE always controlling the surface of the epithelium of the intestine in order to avoid the penetration of these germs. IgA and IgE, as I said, IgA always try to cover and to protect the surface of the mucosa by neutralizing the antigen. Now, if the antigen did make it through, we will have IgE and mast cells. They will, of course, trigger the inflammation. So there is always a cooperation between also different classes of antibody as well as different type of cells. And here is just a summary of our antibody neutralization and protection. So antibody can neutralize the microbe in order to avoid that the virus or the bacteria will go to the viral receptor, for example, here viruses. That's why we need always serology to know if we have antibody. They can also kill bacteria by blocking the nutrient transport molecule. So this bacteria cannot be fed since the nutrient cannot go into this bacteria. Or of course they can stop toxin like tetanus. Antibody against tetanus in order to avoid that this toxin can go to the receptor. Voila. Some of the major functions of these B cells, extremely important. We didn't see all. We hope, and I hope sincerely, that we can have also other conferences on some subclasses of IgGs and of course immunopathology. I would like really to thank, first of all, the responsible or of VitaSwitch that allowed me to give you those conferences. I would like also to thank you for listening, for being here, all this, for this 6 sessions. And of course, I would like to thank my technical team who did a great job, Yunus and Samir, who did a very good job in capturing, of course, and giving you the best of what we can in this virtual world. Thank you again for being here. I hope to see you one day. And in the meanwhile, take care of yourself and your family. Bye.